Hello.
Can you hear me?
Hello.
Can you hear me?
Yes, sir.
Yeah.
Hello.
Dr. Samir, thank you very much for accepting today's invitation. This is the penultimate class of this long session, 2.5 months old long session. And the topic is very, very important
Hello.
topic as we all.
Sir, your
Hello?
voice is
Can you
not
hear
clear
me?
actually.
Cannot hear me?
No, sir, your voice is breaking actually. It's not continuing.
Okay. Actually, the network is very. Okay, I'm
Uh,
trying from other devices. Just a minute. Wait for a while. Thank you. Can you hear me now, Samir? Hello? Hello?
hello.
Can you hear me now?
Hello.
Can you hear me now? Hello?
Hello. Yes, sir. Boli.
Yeah, can you hear me?
Yes, sir. No problem. I am hearing.
Yeah.
Say
okay. Good evening to everybody. Dr. Samir, the moderator, and
hello.
today's teacher. I mean, there is some network problem. Dr. Sharkar, are you in the line?
Yes, I'm here. Can you hear me?
Yeah, I can hear you, but I cannot hear Dr. Samir's voice clearly.
Yes, sir. No, sir. Are you getting my voice now?
Now you are getting your voice, of course.
Yeah, actually, I don't know what was happening. Your voice was breaking, I think.
Is it breaking still?
No, it's okay now.
Okay. Today, thank you. Good evening to everybody. I welcome all of you. Today's topic is benign prostatic hyperplasia. Benign prostatic hyperplasia, as we all know, it is almost synonymous with urological practice at one time. Nowadays, due to expansion of different variety and different recognition of different diseases, the span of urology has extended to a very higher extent. But there was a time when people used to find out if you can do a good surgery for the prostatic obstruction, then you are an urologist. Today's discussion is on a topic, I think everybody, each and everybody, those who are present today will have to survive on this surgery for the next few years unless some dramatic changes in the medical management comes. Today's session today's
it's 7 o'clock.
The most rising urologist and endourologist and laparoscopic urologist who has taken the charge to conduct today's meeting, along with Dr. Kalyan Kumar Sarkar, our president, Dr. Srinivas Narayan, and Kalyan Kumar Sarkar, Dr. Srinivas Narayan, Dr. Samir Swine, and other teachers and the students, 4 students, those who are already present today. I welcome all of you for a very exciting evening, which will cover most of the topic which are required to cover the BPH session. There is a small changes in the schedule that Dr. Benu Panigrahi, due to some personal problem, cannot join with his video presentation. I requested Dr. Samir Swine to discuss his topic of open prosthetic surgery during some of the case discussion. And as Dr. Kalyan Anjan Kumar Das is not able to join today's session, so I personally welcome Dr. Srinivas Narayan to take over his place and please conduct this session. And for students, please take active part to make this session successful. With this, I hand it over to Dr. Samir Swine to continue the session. Dr. Sarkar, if you want to comment something, you please add up.
No, nothing. I was I'm happy to take part and fill in for Anjan Das. What is my role? Shall I mean,
as a teacher.
Okay. I had. Do I have to present a case discussions are all ready, are they?
Yeah.
Or I have a case on BPH with bladder stones, which Doctor, I thought that was my brief. Is that so? Samir?
Yes, sir.
So just tell the sequence of case presentations and let's get going.
Sir, initially Dr. Shashanka will be presenting.
Yeah. Dr. Shashanka, has he joined? I can see him. Dr. Shashanka?
He has not joined.
I am already in.
Oh,
yes, he is
welcome, Shashank. We couldn't see you. Welcome. How are you?
I'm good. How are you, Da?
Good. I am all right. We will going to meet very soon in different platform.
Okay. Sure.
So, welcome to this evening and start the session. So, moderating the session today.
Hello.
We can hear you, Samir.
We can start.
Yeah.
We can plan.
Yeah, you please start.
Oh,
please start the session.
Good evening, all. With big thanks to Dr. Ranjan Dey and Kalyan Sarkar sir. I welcome all the faculties, supervisor teacher, and the evening online classes, the postgraduate. And also, I must welcome the residents who are there today for the today's program. Prashant Chaudhary, Dr. Shahid Hamid Kumar, Dr. Kuslendra Kumar, and Vishal Naniwal. So all are present?
Yes.
Hello. For today's program, there are 4 residents. Hello.
Samir, I have a suggestion.
Yes.
Always take 2 students for each case. Let there be repetition. So take 2 students for each case, and they will get better option to present themselves.
Interaction. Yes, sir. That's okay. Yeah. So for the first case, Dr. Shashank Barua will be presenting case 1, and Dr. Prashant and Dr. Shahid both will be joining for that case. Okay. So Dr. Prashant and Dr. Shahid and Dr. Shashank Barua, all 3 are welcome. And I hand over Dr. Shashank Barua to conduct the next session. The time is 30 minutes.
Okay. Thank you, Samir. Good evening, everyone. Welcome to this Zone evening classes. I'll be presenting a clinical scenario of a patient with benign prostatic hyperplasia, and we would like to know from the students as well as from the teachers their opinion regarding the history taking, starting from the history taking up to the evaluation and the management. So this is a 65 years old Hindu male who had history
just to interrupt you, Dr. Shashank, just better to have a little bit of introduction of the residents who are for this session to both the residents. Okay.
Samir, my slides are visible?
Yes, all are visible.
Okay.
It's okay.
Thank you so much.
Okay. You just have an interaction with the resident and please carry on.
Sir, myself, good evening, respected teacher. Myself, Prashant Chaudhary, third year PGT from RG Medical College.
And who else?
Dr. Sahid, are you joining? Okay, any other resident available now? Dr. Vishal and Dr. Kusti?
Good evening, sir.
Yeah, Vishal, you can join also. That's not
Yes,
a problem.
sir.
Okay,
Good evening,
Dr.
sir. Myself, Vishal.
Hello.
Today, somehow there is some network problem, I believe.
Yeah. Dr. Vishal, are you joining?
Hi, yes, sir. Good evening, sir.
Okay. So, Dr. Sasango, Dr. Vishal and Dr. Prashant, both are there. You can proceed.
Okay. This particular case will be taken up by Dr. Vishal and Prashant. So kindly concentrate on my slides. So this is a 65 years old Hindu male who had symptoms of frequency of micturition, urgency, hesitancy, intermittency, nocturia, and sense of incomplete evacuation almost for a duration of 2 years. There is no history of hematuria, and 18 months back during the COVID time, he went into acute urinary retention for which he was catheterized and put on oral medication that constitute silodosin and dutasteride. So he was on monthly change of catheter since then and could not attend the medical college because of the COVID scenario. In between, he had failed trial without catheter 2 times while he was on combined medical therapy. He doesn't give any history of any other symptoms except that he is a known hypertensive on tablet telmisartan 40 milligram once daily for 1 year during CH. He was diagnosed with type 2 diabetes mellitus and presently on insulin therapy. There is no history of suffering from any major illnesses in the past. He only takes the telmisartan for hypertension as well as silodosin and dutasteride for last 18 months. That was also not regular. There is no history of intake of any anticoagulant or any history of any drug allergy. His all family members are enjoying good health. There is no major illnesses in the family. He is a non-vegetarian, takes average Assamese diet, non-smoker, non-alcoholic, doesn't have a history of chewing of tobacco. His bowel habits are normal. He is sexually inactive at present. So to summarize from the history, is a 65-year-old male who is a known DM and hypertension with a bothersome LOTS with 1 episode of acute urinary retention for which he was catheterized and currently on combined medical management and history of failed twice TWSC. So this is the summary. Any other information which you would like to know, Prashant?
So, is patient taking any anti-psychotic drug like tricycline or any cough syrup?
No. There is no history of intake of any such type of drugs prior to the episodes of acute urinary retention. Vishal, any other information you would like to know from this patient?
Sir, no, sir.
You are satisfied with the history?
One episode of
Sir, there is any history of lithuria,
No, no
hematuria?
history.
No history. Okay, sir. Any sir past instrumentation, any lower
No,
unit
not at all.
surgery?
It is the first time that he has got medical attention.
Okay, sir.
Any other information? Other students who are watching, you can also join us. And if you want to know any other information, or are you satisfied with the history, what has been given to you, and the summary?
History of constipation.
Very good. So there is no history of constipation in this patient.
Any history of incontinence of urine, sir?
No, not at all. Now, Prashant, why the history
Yes,
of constipation is important?
so because in cases of sir, there is bladder wall syndrome, or in cases of constipation, there may be precipitate acute urinary retention. So this is important.
Or any other information we might get if the patient says that yes, he is a habitual constipation? Something
Habitual.
to in our mind? Yeah, he is having chronic constipation. If the suppose patient of this age, 65 years old male, having lower urinary tract syndrome and also had his constipation, does it signify something, or we can simply ignore it?
It may lead to say acute precipitate acute urinary retention or
Yeah, it can precipitate, no issue, but the thing is that
sir, in neurogenic bladder, like patient is
yes,
diabetic.
definitely. We can also take into account the possibility of coexistence of neurovesical dysfunction. So therefore, the history taking, the importance of constipation is important, particularly in the aging male. Any other information? Other
Sir,
students can also participate.
Patient given long history due to COVID, sir, along with the in previous history before AUR, any previously history of LUTS?
Yes, he had predominant symptoms, storage symptoms, as well as obstructive symptoms, which was followed by an episode of acute urinary retention. He was catheterized, then put on silodosin and dutasteride. Then somebody else trial without catheter twice but failed, again recatheterized, and now he's awaiting intervention, further intervention. Now with this history, what it can be? Vishal.
Sir, my first diagnosis on this base of history, bladder outlet obstruction due to the enlargement of the prostate.
Okay. So, a 65-year-old male having bothersome LOTS.
Yes.
So your first assumption is that the patient might be harboring an enlarged prostate that has led to bladder outlet obstruction and acute urinary retention. Okay.
So, yes, sir. Along with I also put some differential diagnosis. My second diagnosis may be CA prostate.
Okay.
And third is, sir, BPH, which with bladder calculus.
Okay.
And
Prashant, would you like to add something, or it suffices?
Neurogenic bladder, because the patient is diabetic for last 2 years, and maybe a bladder tumor which obstruct the bladder outlet, sir.
Rajan sir. Rajan sir.
Any problem? We can continue. Hello.
Okay. Now, any comment from our teachers regarding the differential diagnosis that the boys have put in?
You can have your own opinion, whatever it may be. You are the boss now. After the session, we will discuss.
Okay.
Okay.
Okay. So both of the students, they have agreed on that this is a bladder obstruction because of the prostatic enlargement, maybe a BPH or a carcinoma prostate, or maybe associated BPH with a vesicle. And Prashant has said about a big tumor in the bladder neck that is obstructing. So that was the diagnosis, but I think that should not come now because he doesn't have any other symptoms that's suggesting that particular pathology. Okay, fine. Then we'll directly go to the general examination. So these are the findings of the general examinations that accept that he is having a bit hypertensive, 130/86, it is under control. Otherwise, there is no positive finding in general examination as well as the para-abdominal examination. Right? So this is his pictures, clinical picture. His abdomen. Then his respiratory system was examined, CPS examined, CNS, everything seems to be within normal limit. Now the examination of the external genitalia. Kindly concentrate. This forms a very important part of examinations of any patients who complains of lower urinary tract. You do not always concentrate on the prostate. Patient might having some other pathologies that also may cause obstructions right at the external meatus. So examination of the genitalia. So prepuce is normal. In case of penis, the glans is normal, meatal opening is normal, no stenosis, parietal catheter in situ, scrotum and testis seems to be normal. So this is the clinical picture you can see. There is no abnormality as such in gross which can be visible or can be appreciated on clinical examination. So genitalia is perfectly aligned. Now comes the digital rectal examination. So in the digital rectal examination, this anal tone is normal. There is intrarectal, significant intrarectal bulge of the prostate and clinically more than 3 centimeters where the upper edge of the prostate could not be reached with the index finger tip. It was non-tender. There is no nodularity. Consistency is the firm and mucosa of the prostate is normal. Perianal sensation is intact. Back and spines seems to be normal. So these are the findings which is in front of you. Any other information you would like to know?
As a patient is diabetic, we also check when patient in on catheter, we can also see the bulbocavernous reflex at that time.
Yes, good, very good. So BCR was elicited. Vishal, what are the different ways that you can elicit the bulbocavernous reflex while examining the patient in the OPD? If the patient is on catheter and when the patient is not on catheter.
So when patient in catheter, one finger, one index finger put in the anal opening and the catheter slightly upward pull, and to look the perianal contraction, sir.
Yes, that reflex means there will be squeezing into the finger. You will experience
Squeezing of the
squeezing effect. Okay.
Yes, sir. Yes, sir.
If the patient is not on catheter, then how will you elicit this?
Then, sir, sir, in the medial thigh, sir, sir.
Okay. Anyone who can add to this? If the patient is not on catheter,
actually there is two methods. Actually, there is two methods of seeing bulbocavernous reflex. One is by visualization, and second by the palpation. So, in first, if patient on catheter, we just gently pull the catheter and see the perianal constriction. And another method is we put index finger in the anus and same procedure repeat and see for contraction of anal muscle. And if patient is not fit, then we just squeeze the gland and see same procedure.
Yes, right. Bisal, you got it? So these are the two clinical methods that you can elicit the bulbocavernous reflex when you examine simultaneously along with digital rectal examination. So in that case, bulbocavernous reflex seems to be intact. These are the clinical findings. So now to summarize after clinical examination. 65 years old male, known diabetic and hypertensive with burdensome LOTS, with history of 1 episodes of acute urinary retention, with failed trial without catheter twice, and physical examination reveals grade 4 enlargement of the prostate, which seems to be benign on clinical examination. He is currently on parietal catheter, which is draining well. So this is the information which you gathered from the clinical examination. Any other information which you'd like to know in this particular patient?
So patient on not any anticoagulant?
No.
Patient.
He is not on any anticoagulant.
Not on anticoagulant. Sir, timing between both TWOC?
The timing between TWOC is 1 month.
1 month.
Yeah.
Is sufficient.
Any other thing you'd like to know? Just you revise yourself that this is a patient, 65 years, elderly patient, having 2 important comorbidities, that is diabetic and hypertension. And he has burdensome LOTS that culminated into acute urinary retention. And he failed TWOC twice. Now he's on catheter, awaiting further management. Any information you want from this patient? Any further information? You have already satisfied with the history. Now, any further clinical examination necessary, or we can directly proceed for investigation?
Already done valvulocavernosus reflection. So we proceed for investigation, sir.
Okay, you would like to go for investigation. What investigation will do?
Sir, routine blood, urine analysis, and serum pH.
Only urine analysis? You're not going for a culture test?
For culture also.
Okay. So Vishal, he said he is keen to do urine analysis and culture, routine blood test, and along with that, he wants to do PSA. Now, how far you can justify of doing a PSA in this patient? Whether a PSA is indicated and what is the current recommendation?
Means current recommendation only for offering sir PSA, because if rising PSA is some change in management of LUTS, then should be is useful. Otherwise, no any useful for doing routine PSA level, sir.
What is the Indian guidelines is?
Sir, Indian guidelines.
What is the Indian guidelines is?
On sir examination first in without any positive symptoms, sir, and no need for routinely do PSA.
His digital examination is normal. Seems
Yes,
to be
sir.
a benign prostate. There is no evidence of any during history as well, clinical examination. Now he says he wanted to do PSA. Now, how far is justified? What is our USI guideline says about performing a PSA test in the patients with LOTS due to BP?
So actually in new guideline, most all patients undergo for PSA level, because some cancers are not, in some cancer PSA value is not increased, like undifferentiated adenocarcinomas, neuroendocrine tumors, and the other variety of which is not an adenocarcinoma of prostate. So newer guidelines is we do serum PSA.
So if we do serum PSA, is it an opportunistic screening or it's directly don't? You want to do a screening? Because in India, we don't have screening guidelines for prostate cancer till now.
Not for India, for in newer guideline for European guideline, because
No, that is for a
it's changed
prostate
the
cancer.
management. It's
Does
changed the
the
man.
okay? Does it related to the age of the patient as well as his life expectancy? Any recommendation regarding the age of the patient?
Yes,
Or
yes, sir. If it is
that the
life
PSA value,
expectancy more than 10, then it is important.
does the PSA value, knowing the PSA value will change the management in this patient?
So, if PSA value is more than 10, it is considered as CA prostate uh, in as European guidelines.
No, I am not talking about, I am talking about this particular case. In this particular patient, whether you are going to do a PSA or not. If yes, you justify. If not, you justify. That's all.
In our scenario, we not go for PSA because digital rectal examination as well as
Okay. In other words, you must say that this is an optional. Okay. If the clinician thinks that yes, I must do a PSA for this patient, he will go for it. And someone says, no, I'm not going because he's a 65 years, he's having a long life expectancy, and doing a PSA and finding out the PSA is not going to influence the outcome. In those situations, you're not going to do a PSA. Okay, fine, you will proceed with the investigations. So
Yes, sir.
this is the routine urinary analysis, which shows 3 plus glucose, protein, pus cell 4 to 6, RBC is 0 to 1, epithelial cells 1 to 2. Just remember the findings. These are the routine blood which you have asked for. Creatinine is okay, but his RBS is 302. These are the only findings. And urine culture shows mixed growth after 24 hours of aerobic incubation. Remember, he is on catheter. This patient was on catheter. So most probably it's a contaminated sample.
Yes,
sir. So these are the findings. And you need to know about the PSA. Yes, PSA was done. It was 1.93 nanogram per ml. Any other information you'd like to know now? What other investigations which you'd like to do?
ultrasound, abdomen, and ultrasound KUB.
Ultrasound KUB. Okay, fine. This is for you. You see the huge enlargement of the prostate, and there are also, what are the findings you have seen? Just describe the findings.
Sir,
Yes,
actually, very large prostate with small median lobe and thickening of bladder wall seen.
Yes, that means what
And
does it
there is
mean?
Foley's catheter, Foley's valve also seen in catheter ultrasound.
What is the bladder wall thickening indicates?
Sir,
More than 5.
chronic obstruction, bladder wall of patient is thickened.
Yeah.
Back pressure change, which.
So this is the, you can see the amount of enlargement of the prostate. Okay, you can see now, you can well visualize the median lobe. You can see now the median lobe. In this particular section, you can see the intravesical prostatic
projection.
Any other information which you can gather from this particular ultrasound picture?
So PBR.
Patient on catheter.
Patient is on catheter.
Sorry.
This was done.
Patient on catheter. Oh,
this
sorry.
was done after removing the catheter, filling the bladder to appreciate the median lobe.
Median.
This is just to show you the median lobe. That is why the catheter was removed, so that it can be better appreciated. This was done in the bedside. Okay. So, can you enlighten us about the intravesical prostatic protrusion? What is this, and how you can assess the intravesical
it is graded in 3 up to 5 mm. It is grade 1. Up 5 to 10 mm, grade 2, and more than 10 mm, it's grade 3.
Grade 3.
Do you know who has proposed this grading?
Keto, sir.
Yeah. Pardon, please.
Keto.
No, he's a urologist from Singapore General Hospital. K2 Fu. He has proposed this particular grading system for intravesical prostatic protrusion. So this is the ultrasound findings. Bilateral kidneys are normal. However, the prostate is enlarged. Volume is 102 cc. Heterogeneous co-texture. Intravesical prostatic protrusion measures 2.1 centimeter, and the bladder wall thickness is almost 4 mm. This is done in our department. Plus, you can see the anatomy, zonal anatomy, central zone, peripheral zone, and there is no suspicious hypoechoic areas which was detected in the truss also. Okay, seems to be benign enlargement of the prostate. Now, what is the provisional diagnosis from you? I have given you everything, all investigation which you have asked for, everything is in front of you.
So it is most probably a 65-year-old male with bladder outlet obstruction due to prostatomegaly.
Okay, so it is a benign prostatic hyperplasia.
Yes.
Yes, so now this question will be now open for almost all the postgraduates who are attending this class. What is the plan? So in other words, what are the treatment options which are available currently with us for management of 102 gram enlarged prostate in a patient who is diabetic, hypertensive, 65 years old and fail?
So after taking anesthesia fitness, we have option for open prostatectomy and laser enucleation, laser vaporization, and bipolar enucleation.
Okay. So the person says that he is going to take up this patient for surgery and he will go for an anesthesia clearance, and his options are: number 1, open prostatectomy; number 2, laser enucleation; and number 3, bipolar enucleation.
Can I come in? Hello.
Hi.
Hi, I am Dr. Srinivas Narayan. I'm just asking Dr. Prashant Chaudhary to enumerate his choices according to his preferences. Whether he will ask for he will go for an open prostate first, or second will be the laser, or third will be the bipolar enucleation. What about bipolar TURP?
Sir, actually prostate size is 102 gram. So there may be a chance procedure may be lengthened, and there is water load.
No, Dr. Chaudhary, I am asking your preference. Given a choice, if it is your patient, what you will offer to the patient? You have to write something, na?
Serially, according to your preference.
Sir, laser enucleation.
Laser enucleation. Which laser we are going to use?
Currently, sir, thulium fiber laser is.
See, dear man, that's why I am asking you, what you will write on paper. You cannot write laser enucleation and then you start pondering whether I will use holmium or thulium or something, or thulium fiber laser. You have to write something. You are going to be consultant.
See, you have to give according to the preference. There are a lot of surgical opportunities are available, or in your urology's armamentarium. You have to choose among them, and you have to justify why you are choosing this.
Because in cases of thulium laser, depth of penetration only 0.2 mm and complication rate is lesser. So, sir,
So you are still sticking with the thulium fiber laser enucleation.
Thulium or helium, sir?
Again, changing. Okay. So you're not interested with the bipolar. You're not interested with the TURP. Have you seen this much of big prostate TURP being done?
Sir, maybe done in stages or.
Yes, it can be done in stages. It can be done in the same sitting also. I think Pradhan sir, if he is available here, you are supposed to be available today, Pradhan sir.
Can we ask what will be the preference for Dr.
Vishal? Dr. Pradhan is probably not joined.
Okay. Dr. Vishal Kumar, can you enumerate your choices?
Yes, sir. first that the patient is the fasting glucose is 302. So first is glycemic control along with the patient history of long catheterization. So given antibiotic coverage with all pre-anesthetic checkup done, and then offer then ask the patient then ask the patient to about the disease, and given your given treatment option, maybe open prostatectomy, bipolar TURP.
No. Dr. Vishal Kumar, I am not asking for option. The patient is
Yes, sir.
sitting in front of you in OPD. You have to write something
you are
on
going to
paper,
do?
sort of thing. What you
Sir,
are going to do?
Sir, in this case, I am doing the open simple prostatectomy. My first choice.
Your first choice will be open. Okay.
No.
Yes, sir.
Which approach you are
Why open? Why open? Why not endoscopic procedure? But I can vouch for it. If you opt for an open surgery, 9 out of 10 patients will run away from you.
Yes, sir.
So why open?
Sir, when then everything is available, then my plans would be changed, sir.
See, this course has been, this examination view has been taken that you should answer very confidently during your examination. This is not like
Yes,
when
sir.
you say that open surgery is my first option, and thereafter start pondering that if everything is available. Given a choice,
whatever you say, you must justify.
Justify.
Whatever
You should justify.
you must justify.
Yeah.
Okay, sir. In this case, sir, my first preference in bipolar TURP, sir.
That's good. That's good.
Okay.
Yes, sir. Sir, another option be sir, holmium laser enucleation of prostate, or sir, thulmium laser fiber enucleation, and if another thing possible, then open simple flares, suprapubic flares, open prostatectomy, and maybe simple monopolar TURP, sir.
And what about the other lasers? You are not going to use any other lasers? You have said about thulium laser, fiber laser. You have said about holmium laser. Why to left the conventional thulium lasers, then the KTP lasers, then the diode lasers, so on and so forth? You have to justify now why you have chosen to do a thulium fiber laser. Why? See, you have said, you haven't said, you said it yourself. So you now justify why you are choosing thulium fiber laser. You have
sir,
with you.
In conventional lasers, more surrounding damage, and compared to the newer generation thulium and holmium laser, less depth penetration, so surrounding tissue less damage, and low operative time, and low complication, less complications.
When you talk about laser, you have to talk about the precision at which a laser cuts.
Dr. Shashankar, almost a little bit more. Kindly make it short so that we can complete within time.
Okay, see, in this particular patient, it's a huge one, big prostate. So if you are given a choice, so if you are well trained and know how to do a TURP, you can always use a bipolar TURP, because using a monopolar TURP, there may be chances of a prolonged session. So that might invite certain complications which can be avoided by using a bipolar. Understand? So you must justify why I'm using a bipolar. You're right, absolutely right in saying that yes, I'm going to do a bipolar TURP. And if you are not satisfied with the single stage, okay, you can stage the procedure also. Many people do it. But you must know the advantage and disadvantage of the particular procedure which you mentioned in the examination. When you say laser, it is not like that key laser also have got shortcomings. So which laser is preferable? As of now, which laser scores one above other? So that you might know how holmium scores over thulium, or how thulium fiber laser scores over holmium. So those comparative points, 4 or 5 points, there are no much point differentiating point, but 4 or 5 points are there, very important, and those has to be mentioned when you are asked in examination 1, 2, 3, 4, 5. So this is the reason why I am using thulium fiber laser. So this is the reason why I'm using a holmium laser enucleation. So when you say holmium laser enucleation, or you say laser, I will do a laser prostatectomy. So there are two methods. One is ablation, another is enucleation. So out of that, which one you will choose? So those things has to be clearly mentioned. Or if it is a theory question also, you have to mention very precisely and clearly. I am going to do this. Don't write haphazardly everything together. Okay, I'm doing the laser prostatectomy, thulium, holmium, diode, KTP, so on and so forth. Not like that. So serially, according to your preference, right, and write their advantage as well as their disadvantages. Okay? And giving a big prostate means this is a clinical challenge to everyone dealing with a big prostate, because these prostates are usually very bulky, very hypervascular, and you need to be overcome at all the time when you do a surgery, be it a bipolar TOP, monopolar TOP, or a laser prostatectomy. You got it, Vishal, Prashant?
Yes, sir. Yes, sir.
Your first will be that if you are going to do a bipolar TOP, you must know that why I'm not choosing a monopolar energy source, why I'm choosing a bipolar energy source. Why? What are the advantages? Can anyone just want to see? Just can you tell us what are the advantages of using a bipolar energy source instead of doing a monopolar?
Less.
So most dangerous complication of monopolar in large prostate is TUR syndrome, sir, which is less in cases of bipolar. So we can resect larger prostate in saline resection.
Okay. Then?
So cutting is very smooth in of bipolar.
Hello.
Samir.
Yeah, actually, you have to complete a little bit fast.
Okay. So shall I stop here?
No, you can wind up within a few minutes, maybe 2-3 minutes.
So let us wind up, and for the students, those who are present here, you see, this is a patient, 65-year-old male, and having diabetes, hypertension. So when you contemplate surgical intervention, one must also consider the presence or absence of any comorbidity condition, because patient with a long-standing diabetic, this patient will most likely to have some amount of diabetic cystopathy as well as diabetic uretropathy. So therefore, the counseling of the patient before embarking on a surgical intervention is very, very important. Nowadays, the question of the CPA comes, and you'll be in trouble if the patient keeps on leaking urine after that. So therefore, you always counsel the patient before taking him to the OT. Make him understand what procedure you are going to do, what are the other comorbidities that are present in him, and that may influence the outcome of your surgery, like diabetes, or those patients who had a history of cerebrovascular accident, or particularly the patients with Parkinson's syndrome. Those are the patients who are very critical and very difficult to choose when you are going for a surgical intervention, because most of the time 30 to 40% will not improve, or they will have a residual symptom. So that has to be properly explained to the patient as well as his relatives, so that he accepts your judgment and you can carry on this surgical intervention. So counseling the patient is important part. Choosing a particular energy sources is another important part, and following up the patient for any complication or any untoward event is very important. Just we cannot wash our hand by doing a HOLAP, okay, fine, you go. No, you must follow up, because it's all procedures are not devoid of any complication. Later on, the patient may develop stricture or brother stenosis. So you must follow it up. So those just don't perform the surgery and leave the patient back. Insist on him that he should be compliant enough, and he should be on a regular basis follow up with you at least for a few years after doing the surgery. So that's all, and thank you very much, Samir. Almost all, but there are certain things the students should also come up, particularly the clinical examination part, and choosing a surgical technique, which one will be the best for a particular patient, that is influenced by many factors, and those factors has to be taken into account. Thank you so much.
Yes, absolutely. It's a nice discussion to start with. Probably other two students has not been joined till now.
Okay.
So Dr. Prashant and Vishal, it's better for you so that you can continue and have a wide spectrum of discussion. for prostatic hyperplasia. So for the next case, I
Good evening,
request.
sir.
Hello.
Good evening, sir.
Yeah.
Sir, I am Dr. Shahid.
Okay, you have joined. Okay, Shahid, welcome. So you will be the next candidate, and for Prashant and Vishal. So Dr.
Yes,
Vishal
sir.
and Dr. Shahid will be for the next candidate.
Okay, sir.
Probably. Okay. So I request Dr. Kalyan sir to present the second case and have a discussion. Prashant sir, we
Okay,
all know
I'm ready.
Dr.
Allow me
Yes,
to share the screen.
Yes, sir. And for the next case, Dr. Prashant and Dr. Shahid, you both will be there.
Okay, sir.
Dr. Bodiwal.
Yes.
Dr. Shashank, please on share your screen.
Unshare your screen.
It's not audible. What happened?
Hello.
Yeah.
Please on share your screen.
Okay. It's okay now?
Yeah.
Okay.
So Dr. Kalyan sir is requested to share his presentation. Kalyan sir, are you ready? Hello. Kalyan sir, are you there? Hello. Okay. So over to you, sir.
Yeah, okay. Good evening, everyone. So, who are the students on this case? Hello.
Dr. Vishal and Dr. Shahid.
Okay. Okay. Now, can you hear me? Can you hear me all?
Hello.
Can you hear me all?
Yes, sir. Voice is audible, sir.
Okay.
Please proceed.
Okay. So this is my patient is a 65-year-old male patient who presented with acute urinary retention some years back, and this was preceded by a history of poor flow, frequency, incomplete bladder empty. So he had a distended bladder. So this is our patient, distended bladder, 65-year-old male. He had significant symptoms of obstructive lower urinary tract symptoms for 3 months. The bladder was distended. On rectal examination, he had good anal tone. Prostate was moderately enlarged. So how are you going to proceed? Who is going to take the questions? Vishal?
Good evening, sir.
Good evening. So this is your patient.
Yes,
How
sir.
are you going to manage it? He's 65-year-old male.
History of AUR in 2017, along with the history of obstructive LUTS for last 3 months.
So this is your patient. You've been called to emergency to see this patient. How are you going to manage him? He's 65 and has come to emergency, unable to pass urine. How are you going to manage him?
Yes, sir. I am first asking to patient about the at the time of previously AUR, what treatment should be prescribed, and how many times in this time either peritoneal catheter or any other method used to relieve the retention, and also ask also along the ask any thereafter any history of any instrumentation and how long time to patient on catheter. Thereafter,
So let me tell you, this is I'm asking you, Vishal, that this is your patient. You've been called to emergency to see this patient, and how are you going to manage him? He's got a distended bladder, despite the distended bladder, this is him. So what are you going to do now? And I told you that on physical examination, he's got a distended, you could feel, despite the bladder being very distended, you could feel a moderately enlarged prostate with good anal tone. So what are you going to do for him?
Sir, first gentle attempt to peritoneal catheterization.
Okay. So you catheterize him and you decompress the bladder. And what are you going to do next?
If in this case bladder is huge dilated, and so after the decompression and per catheter placement, and then about ask the some history about the patient.
So he's a known case of hypertension and diabetes. And then what are you going to do next?
Yes, sir. In this case, after the acute sitting, it's
what are the basic investigations you will do? What are the basic investigations you're going to do for this patient? Say, we've seen him in emergency, we've catheterized him, and now he's in the wards.
Yes, sir. Along with routine investigation, routine blood and urine routine and urine culture with ultrasound, abdomen and pelvis, sir.
Okay. So he's got a prostate of estimated to be 62 mils on transabdominal ultrasound with an indwelling catheter in situ. Luckily, his upper tracts are normal, but he's got some bladder stones. Renal and urea creatinine are normal. A PSA was sent and it was 3.57. So this is his ultrasound. So Shahid, tell us.
Yes, sir.
He's admitted in the wards under your care, and what are you going to do to him?
Sir, may I know the size of the stone?
There are multiple stones in the bladder. You can see some. They're about 2 centimeters in size.
Just
not one, there are multiple stones.
I would like to medically stabilize this patient. Sugars. And urine examination and urine culture.
So all have been done. He's a fit candidate for surgery. He's got an indwelling catheter. He's got an ultrasound,
Yes,
and showing bladder stones. So how are you going to proceed?
So I would like to counsel the patient. Maybe the stone and the prostate both can be cause of his pathology. Both can cause obstruction. So I can counsel the patient that this can be done in 2 sittings, or it can be done in same sitting, whatever will be the patient's choice. First, we can tackle the stone. We can remove the stone. We can operate the patient and do cystolithotrypsy. If these are small multiple stones, we can do cystolithotrypsy and then give a widening trial. We can counsel the patient like that, or we can counsel the patient that we can tackle both, because stone seems to be around 1 centimeter, and the prostate volume is around it is 62 cc. So it won't take much time for the prostatic resection. So both these can be dealt in same sitting if patient is fit for the surgery.
So Vishal, would you do any other investigations before coming to a surgical decision?
Yes, sir. And patient known case of diabetes and hypertension. So, sir, glycemic control and urine routine and urine culture.
These have all been done, you know. These have all
so
been done.
We can do NCCP to confirm the stone in the any stone in upper tract, because he has multiple stones.
Yes.
So why is this
we can
important?
do a clean NCCT.
So can you classify the different types of bladder stones?
So these can be primary stones and secondary stones.
Secondary stone.
So is not there a third type of stone in the bladder?
Huh?
Why do stones form in the bladder?
Sir?
Why do stones form in the bladder?
Because of stasis of urine bladder outlet obstruction, urine remains in the bladder for quite some time, and there occurs precipitation of the crystals. This is one that forms inside the bladder. The most common are that are formed in the upper tract. And then they come down the ureters, and then they enlarge in the bladder.
So what are those stones called?
The stones which are primary stones.
Sorry?
So they are primary stones.
Migratory stone.
Migratory stones. So what other investigations apart from an ultrasound of the urinary tract would you do? So before you sort of come to a treatment decision, you would do a plain CT scan, or you can also NCCT. Now, could this be a primary bladder stone?
This patient has obstruction. There is prostate enlargement. So there are higher chances that this can be a stone which is formed inside the bladder.
Okay. What is the age group at which primary bladder stones present?
Children
and in endemic areas.
Yes. Why is it endemic in certain areas?
Due to protein deficiency and malnutrition.
Okay, accepted. What is the age group at these that they present? Well, okay, you said that's children
10 to 15 years.
So, actually younger.
Yes.
They present at the age of 3 to 5 or less than 5.
Yes, sir. Yes, sir.
How do migratory stones present?
It's 8 o'clock.
How do migratory stones present?
The patient usually presents with a past history or present history of a colic, during which the stone migrates into the bladder, and then acute urinary retention following the colic.
Okay. So here you've got this patient now with a stone in the bladder, which is not too large. The ultrasound report indicates that there are few more stones. The NCCT also shows something similar. So you've told me that you would ask the patient to decide. Why? Are there not any clear-cut indications? What is the right thing to do? Or what are the complications of dealing with both? What do you want to do here? Vishal, can you tell me?
Yes, sir. If the stone size less than in this case, stone size multiple stone and size less than 2 centimeter, and prostate size is 62 cc. And after the pre-anesthetic checkup and patient stabilized and patient plan fit for surgery, then first thing, if the stone possible endoscopically removal, then simultaneously do the TURP with endo CLT, sir.
Okay, so what are the cons of doing that? You know, there are some advantages. This is a man with a clear, large prostate. He has urinary tract, he's had a prior history of lower urinary tract symptoms. So he's diabetic, however, and
Yes,
you do his prostate and the bladder stone together. What are the risks?
Risk in this case, maybe a chance of the sepsis infection.
Yes. So that's a risk. So what would you do? This is your patient.
Yes, sir. Before the plan of surgery, given some time of prophylactic antibiotic to settle the infection, sir. Then plan for surgery, sir. What
surgery? So what is your advice to the patient? Your considered advice as a consultant in your practice, what would you offer this patient?
Sir, in this case, sir,
as Professor was asking in the previous case, you've got to counsel the patient properly.
Yes, sir.
With some evidence also. That's what I'm wanting. I want some evidence from you. What are the pros and the cons of operating, doing both the surgeries together, and or in a staged fashion?
Yes, sir. In this case, after explain the patient about the disease and the condition of disease, and then given option, and if the possible, then in one sitting doing the endoscopically removal of stone, then this is endocystolithotherapy with monopolar TURP, sir, if possible. And
okay.
Yes, sir.
So that's what you would advise. He's otherwise fit. Yes, you've got good antibiotics these days. He's otherwise fit.
Yes.
That's what you would advise. So how would you deal with the bladder stone and in this patient?
These bladder stone are break and segmented and removal by endoscopically cystolithotherapy, sir.
How would you do that? Have you done it?
Yes, sir. Yes, sir. With
sorry,
stone punch,
tell me what is the instrument? What are the challenges in dealing with bladder stones endoscopically, transurethral? How do you do
more
it?
Chance of more chance of damage of the urethra, more chance of stricture formation, more chance of the bladder perforation.
No, you tell me what instrument would you use to deal with this particular stone?
Stone punch, sir.
What are the different ways? What is this operation called? It's one of the oldest operations in urology and in medicine.
Cystolithotripsy.
Yes. Are there other names for this?
Murmeyer.
Lithotrity, lithotripsy, these are all alternative times. So lithotrity and lithotripsy were reserved for mechanical device. That's what I was coming to. What are the instruments with which you can crush this stone? Tell me the different forms of fragmenting bladder stones.
So we can use laser energy to fragment the stones, or we can use mechanically lithotrite. We can crush the stone between the jaws of the lithotrite.
Okay.
Or we can use in percutaneous CLT. We can also use this ballistic energy.
Can you name the instrument with which you will crush? Sir was asking that.
Sir, one thing is Murmeyer's lithotrite. Lithotrite, sir.
You see, there are, just for the information, this is something which comes up more in the discussion in the instrument section and also on the X-ray section, but you must know a bit about all the different forms of lithotrity, because the questions can go into very basic things like, why is a dilator called a sound? Can you answer this question? Why is a urethral dilator called a sound? Vishal? Shahid, can you answer this question? Why is a urethral dilator called a sound?
No, sir.
You see, in the ancient days, they would pass a dilator into the bladder, and the clinking sound of the dilator hitting the stone would allow you to diagnose in days when there were no X-rays. So these are very simple things of urological history, which you must know. So anyway, I'm not going to go into that, but you can do mechanical lithotripsy, you can do laser lithotripsy. But you've not mentioned a very, very common form of lithotripsy.
Open lithotripsy.
Huh? Sorry?
Sir,
how do you, what are the other energy sources with which you can fragment the stones, apart from laser and mechanical devices? You can use a ballistic lithotripsy.
Ballistic.
Yes?
Yes, sir.
One more.
Yes.
We can use ultrasonic energy.
Yeah.
You can use ultrasonic energy. You can use electrohydraulic energy.
We can use pneumatic also.
Yes, that's what I said. And what else can you use? An invasive way of crushing this stone. This is a 1 centimeter stone. Say Hounsfield number is 600, 700. Come on, Japs. A completely non-invasive way of fragmenting bladder stones.
ESWL?
Yes, why not? Why not? If you are working in an institute where you've got all the facilities, it's a small stone. You treat the stone.
Less than 900 Hounsfield, we can use.
You can possibly do that. So really, so these are the options. So say you're doing transurethral lithotripsy. So what are the main technical challenge in doing transurethral lithotripsy? Did you use Come on. When you do this, what is the instrument you are going to use to say you are going to treat it with laser or with a pneumatic lithotripter? What is the instrument you are going to use? What is the endoscope you are going to use? Am I audible?
Laser we can use. So laser we can use through a cystoscope. We can pass it through the instrument channel of the cystoscope.
Okay. I mean, the point I was trying to make is that the problem with any of these treating multiple stones, large stones in the bladder, the problem is visualization. Poor visibility, either because of mucosal fragments injuring the bladder, which happens with pneumatic lithotripsy, or in the concomitant presence of a large prostate. So a continuous irrigation device is very useful. Or you devise some sort of way with which you can, you have irrigation and suction so that you can visualize the stones properly. Because if bleeding starts, then often these procedures become difficult. So what other way do you know of removing stones apart from endoscopic procedures?
Percutaneous PCCLT.
Yeah. So PCCL you can do. And how would you manage, would you do PCCL in a child with a large bladder stone?
Yes, sir.
Yes, at a higher risk of complications. You must do it very carefully. What is the main problem with PCCL?
Sir, more chance, large space cavities, so more chances of perforation and stone migration, sir.
You're probably right, actually. Mainly the main problem is loss of tract when you do a PCCL. And in a child, the bladder is mainly intraperitoneal. So you have to be, if you do a PCCL in a child, you have to be particularly skillful and adept at these techniques. And if you do a PCCL, the best way to do it is to ensure that you've got through and through access from the urethra to the through the bladder outside the suprapubic tract. So, okay. So, so really, if this stone was 5 centimeters in size, what would you do?
The option
open.
And
open up PCL.
Okay. Can you do? Can you quickly, one of you, tell me the steps of open cystolithotomy?
So in open cystolithotomy, we make an incision to about 2 finger breadths above the symphysis pubis, which is a transverse incision. Then we divide the subcutaneous tissue and then the fascia, split the muscle, identify the bladder, take 2 stay sutures, and then after taking 2 stay sutures, we incise the bladder vertically in a vertical direction. Identify the stone and then remove the stone, close the bladder in 2 layers, or we can place a SPC through the same tract.
What is the main complication of suprapubic cystolithotomy? Open suprapubic cystolithotomy. Wound infection. Okay, chalo.
Yes,
so now, now we've discussed the various ways you can deal with the bladder stone. Now answer this question to me. How do you, is there any evidence whether you should do the prostate surgery at the same time or staged. So I think Vishal has mentioned that there's a higher risk of infection when you do the two procedures together, which is well taken point. And nowadays with high antibiotics, we get away. But previously when the antibiotics were, there was a higher risk of post-operative infective complications if you did both together. Is there any other issue which may help you, the information you want to give me?
So there is
or
time
any
limit.
other...
Both the surgeries can be done finished within 90 minutes. So we can do both of the surgeries in one sitting. Patient is stable, and we can finish both the surgeries within 90 minutes. Otherwise, it increases chances of the QR syndrome. So we can do both the surgeries at one time if it's a small stone and a small prostate. However, if it is a large prostate, then we can do the stone first. Then after stabilizing the patient, we can even give trial for the prostate enlargement.
Can any of you give me an answer as to whether there is any data on the basis of urodynamics with which you decide, with which you can come to this decision? Any of the other students know? Are all patients who come with bladder stones and prostates, are all of them obstructed? Can any of you answer this question? Right. Chalo. The answer to that is that there is actually emerging data based on urodynamics that about 50% of patients who underwent urodynamics after removal of the bladder stone, only 50% had clear-cut bladder outlet obstruction. As many as 10% had an underactive bladder, and 40% did not. So so personally, it is your decision. But if you can counsel the patient and tell him that that he has the option of trying medical therapy for a trial of catheter and medical therapy, you can do it. So anyway, this patient underwent laser lithotripsy.
Sorry to interrupt, sir. Samir.
Yeah.
Yeah, sir. We'll have to make it first.
Yeah, we'll finish now.
Okay.
We'll finish now. Yes, certainly. So he still had symptoms. Ultrasound showed a residual urine of 100 ml, and so he went on to have a TURP. He had a very low flow rate, so he went on to have a TURP. So that concludes the session. So if there's any of the examiners want to make a point, they're welcome. And I'm stopping sharing.
Hello.
Yes.
Thank you, sir. It's actually very interesting discussion. I think probably you are the most experienced person right now in this forum. And I wish you must give some opinion regarding open prostatectomy in due next discussion. It's very interesting and maybe a lovely point to hear you, sir. So, sir, should we move to next session, sir? Kalan, sir?
Yes, tell me.
We'll move to next session and we'll discuss in between.
Whatever you say. Whatever you say, but I think...
I just want to tell that some points you will tell regarding open prostatectomy. Because probably you are the best person to tell regarding open prostatectomy after the next case.
Okay.
Okay, sir. So next, Dr. Srinivas, are you ready? Hello. Hello.
Dr. Swen.
Yes.
Yeah, I was called in today itself to fill in the gap because some of the teachers was not there because I haven't been told about any of the case to be prepared sort of thing.
Okay. No issue. So we'll have an open discussion right now.
Yeah.
So Dr. Rahul, are you there?
Yeah, I'm there.
So it's better you can have your presentation, and after that we will have a discussion regarding operative procedures by all of the teachers. All of you will be presenting on endourological techniques. So I request Dr. Kalyan sir, Dr. Shashanka, and Dr. Srinivas to give some opinion regarding various operative techniques with interaction in between with the students. So Dr. Rahul, please continue.
Yeah. So I just share my screen.
Yeah, it's visible now. You can continue.
Yeah, I'll continue. Thank you, everyone. Thank you, Kalyan Sarkar sir. Nice to see you, and Ranjan Dey sir to have me here in eZone. So I'm just going to talk about some basics about endourological techniques of BPH and video presentation. This is going to be predominantly for the students who are, who are presenting the cases. And as aptly said, after this, we can always discuss the open technique. So for the today's session, what are the options available? I'll discuss my, the things this way. What are the options available to us, to the students when they are asked in the exam? What is the checklist? How should we proceed in a TURP, and what questions can be asked in the exams? What are the options available? How, if somebody asks you what are the options to treat a prostate, as sir was asking, how to go about the case and answer in the exam, and what is the take-home message for the candidates from a learning process of endourological techniques? See, there are absolute indications from primary surgical management of BPH. We all know that refractory retention of urine, recurrent infections, gross recurrent hematuриas, renal insufficiencies, bladder calculi, as the previous case was being discussed. Though there is evidence that you can give a trial of voiding and things, but it's your way of treating things. If you want to treat prostate along with it, it's no harm. It's a definitive indication of treating that, or permanently damaged or weakened bladders, or large bladder diverticula that do not empty well secondary to enlarged prostates. If these are the indications of doing a TURP, like a candidate is being asked, there is a stone in a prostate, how do you proceed? There is no discussion. If you want to support with the supportive evidence, you can clear cut say that it's a definitive indication for doing a TURP, and I would like to do that the way they've answered. So the present day techniques for endourology, how we classify, what sort of endourological techniques are available? So the techniques available are monopolar, the bipolar, and the lasers. The monopolar and the bipolar are the cautery. Till date in literature, as one of the candidates were answering, the monopolar has a higher incidence of TURP syndrome and things like that. I think that is the talk of the past, because the cameras were not there. Even my father is a very senior urologist. He used to do his TURPs without a camera. I really wonder how he used to manage that thing. But doing that with the newer cameras, the better cautery machines, TURP syndrome is a rare entity. If you have really done something bad or the height of the fluid is not good, then things are different. Otherwise, it's a rare entity. You don't see it. The stricture rate is not different between the monopolar and the bipolar. The outcomes are no different between monopolar and the bipolar. So it doesn't make a difference. Whatever you have, the idea is if you do it properly, you will end up in a good result in the patient. Lasers, definitely, this is something new for the, not very new for the prostate. It's now a decade, almost 10 years have passed, and the lasers have established themselves. But whether every patient needs a laser or not is always a matter of debate. What in India, 90% we are practicing at the area, patient may or may not be able to afford the things. But if it is available, why not? So how do you classify this thing is, other thing is what sort of a TURP you want to do with what sort of instrument. So once we discuss about the instruments, it all depends. Like there may be active sheath, finger operated. Some people use a passive sheath, that is thumb operated. It is in what institute you have worked and what sort of instrument you have been exposed to will help you in doing it in the future part of the life. Because your hand and eye movement is basically the hand-eye movement with you do the TURP. This is just for mentioning, completing the things. This is the rack and pinion working element. In this case, we had to use two hands. I've never seen it. I've never used it, but since it's a discussion for the candidates, so I thought it should be there. So working elements are of three types. One is active, passive, and rack and pinion. So if somebody asks you, this is how it looks like. You use one hand to stabilize the instrument, the other hand to make the cuts with the loop. So again, how do you define the endourological techniques? It will depend on the type of the prostate you want to do. My father always told me that no two prostates are the same. It's not like that if you have done 10 or 20, you are master of TURP. No, it's not like that. Every prostate, whenever you do, you have to plan your prostate surgery. This is one of the surgeries you need to plan if you want to come out, with a peace of mind. So the benign, there may just be the two lateral lobes. There may be a small median lobe. There may be a tag of the lobe which is more prominent. Right lobe may be more than the left lobe, or a big median lobe which you are going to tackle in this case. So this is all depends upon what sort of a prostate you are going to deal with. So the technique will differ in different type of the prostates you are going to deal with. What are the new techniques? If the candidate is asked what is the new technique of doing a endourological management of the prostate, it's the aquablation. Whether it has come to India, not yet. But yes, this aquablation, one of the trials have been done in MPH Nadiad also. Whether it will, how long it will take to come into the practice, I don't know. But it is a reality. People are doing it, and this is how it works. It is a amalgamation of a robotic arm and the transrectal ultrasound and aquablation. How much it will come into India, I don't know. With the type, we have a different category of people to treat with. Literature-wise, as Dr. Kalyan Sarkar said, whenever the candidate does give an answer, I would definitely expect him to know at least one or two papers or quote one or two papers which he, in his support, he should say when he's answering the question. It's not a vague answer like a consultant, like you will say, this is this. It doesn't work like that. Now this debate is now coming to use aquablation. They have done the studies and they have found that it is very good for the large prostates in comparison to open prostate versus HOLAP versus green light PVP. So they're saying it is a very good result. In India, it's not yet started, so I'd not take it there. But from a candidate point of view, yes, aquablation is a new technology. Always remember this, diagram one should be in one's mind whenever you're doing a prostatic surgery, that it's a very vascular organ. And the vessels in the prostate can come from anywhere. It is not only between 12 and 1 or 12 and 3 and 12 and 9. It can come from the base of the prostate, from the lateral lobes of the prostate. So it's a vascular prostate. And this anatomy and generally the branches, it is a branch of the inferior vesical artery. The prostatic vessels come. So one should remember this diagram. This will help you to, plan your surgery. So before you start a TURP, the checklist should be there. Like instruments you see, Otis urethrotomb. I don't know how many of you have used it or seen it, but it's a very good and a basic instrument. I'll tell you in the coming slides why. Cautery, you should always be very aware. Whatever cautery you want to use, monopolar, bipolar, the cautery pad is there. It is adequate jelly is there because you don't want to end up in other things. Irrigating fluid, different types of fluids commonly used as glycine and the normal saline. Jelly should be there, adequate 2 or 3 jellies. Why, I'll tell you. And an evacuator should be there. This is a checklist one should always see before one starts a TURP. And in the exam and instruments also, sometimes the examiner will tell you to take out the instruments for a TURP. So you should always take out all these instruments. If they're in the tray, you should not miss them. So past to present, this is the Stern-McCarthy model of instrument to this. Now the continuous flow resectoscopes, that is the Iglesias model, are designed to eliminate the need for intermittent bladder evacuations. So if the examiner is going to ask you, so there are 2 basic types of instruments available. One is non-irrigating and second one is a continuous flow and non-continuous flow. So the candidate should remember, even if they have not seen in their institutes, because majority now are being used as a continuous flow type of resectoscopes. But for a candidate point of view, you should know the other type available is a non-continuous flow resectoscopes. And if you are using a non-continuous flow variety of a resectoscope, you need to have a suprapubic trocar in, so as to have the low pressure maintained within the bladder. So what do you mean by low pressures? This also examiner can ask you. The bladder fluid pressure has to be below 10 to 15 centimeters of water. If it goes beyond it, then yes, the patient may develop the TUR syndrome. To avoid that, you should keep the height of the the irrigating fluid at 60 to 70 centimeters of water. Otherwise, it has to be low. If you increase the height by 10 centimeters also, the amount of the fluid which will go into intravasation will be very high, and the patient can develop a TUR syndrome. So this is what you do for that. Positioning in the TURP, somebody can ask you. So this is a diagram you should always remember. It should be very well padded. Whatever you may use, the simple lithotomy position is there. There's nothing new or much to it. For a urologist, it is day in and day out. The arm should be by the side of the patient and easily accessible for giving the IV fluids or the TURP. The techniques of the TURP, the first and foremost component of any good TURP is doing a cystoscopic examination. After careful inspection and orientation, the bladder is distended with approximately 100 ml of water. You do a cystoscopy with the minimum possible, smallest possible scope, and you where the external sphincter is, where your verumontanum is, where your bladder neck is, what sort of a procedure the this is the trolley which is already ready and set to go. So first thing is a cystoscopic examination you want to do. So you get it urethra, you want to do a cystoscopic examination, as this will give you the how to plan the surgery. Yes, when you are a senior consultant, you have done about 100 odd TURPs, you may avoid doing a cystoscopy because you're trained by then. But from a candidate point of view, from exam point of view, cystoscope already planned, you see how the bladder is, there are some stones or something is there, you missed, your sonologist friend has missed, or there is some calcification, or how the prostate looks like. And this will give you an idea also how much time will you take to do the job. So placement of the resectoscope sheath should be well lubricated. This is a very important component of any TURP. The most adult urethras allow well lubricated 26 French sheaths. You should come out, you should not say simple, you should be able to know what French instrument you are using. Patankar sheath you are using, if you're using a Mormier's clamp, what is the size of that? If you're using a smaller instrument for the laser, what size instrument you use, you should always know. Commonest being used in India, we are using is a Karl Storz 26 French sheath or 24 French resectoscope sheath we use in India. So if the urethra is tight, somebody in the exam will ask you, if you are not able to get into the urethra, what do? You can use a simple dilatation with the dilators. And if the dilators are there in the tray, you need to isolate them. How much you dilate? 2 French more than the resectoscope sheath you want to use. That is a basic you want to dilate. With the Clutton's variety of dilator or Lister's, whatever you are used to, you can use. The best way to use the dilatation is, I believe, is Otis urethrotomy or a myotomy. And myotomy can be ventral or dorsal, whatever you have been taught in your institute does well for you. The basic aim is not to have a post-TURP strictures. So the principle is not to force the resectoscope sheath. If the resectoscope sheath is not going easily, these are the options what a candidate can answer in the exam. And if the examiner tells you that you have done something and it is not going, what would you do? This is for me, it is historical purposes, because I have never seen anybody doing it. And fortunately, yes, but this is one of the answers what examiner would expect you to give is perineal urethrostomy. You do a perineal urethrostomy, do a TURP, then close the urethra and come out of it. So this is one of the small videos of a lateral lobe resection, in which the resection is being done with the monopolar TURP. So in this, you can see they have started, and any of the the vessels are being taken care of along with as one goes down. What I want to show is that with the bleeding, with the every cut, there can be a bleeding sometimes, and if the vision is not good, you should not proceed and do the resectoscope. In this video, the surgeon is using that, and once it is done, good endoscopic cameras, and this definitely helps you make it faster. This is how they do this thing, resection, because apical lobe, the patient will not void in a good way. That is absolutely going to be there. He's not going to be happy with the outcome of the surgery. And if he goes to your colleague and he just resects this apical lobe nicely, the patient will void nicely. Give all credit to him. Or if you overdo this apical lobe, then the patient will be incontinent. So it is very important whenever the candidates are seeing their seniors or their boss resecting this apical lobe, they should learn how to resect the apical lobe. And how do you do movements, which you can learn only from boss. The basic principle behind a good TURP is keep yourself oriented, as we did for the left lateral lobe. So wherever you want to start, this is one of the techniques. This surgeon has started at about 6 o'clock position or 7 o'clock position. You can do it by the Nisbet's technique or otherwise. But one important point is when you're doing the lateral lobes, you always go back, see where your verumontanum is, and keep yourself oriented. You don't want to go beyond the verumontanum and mess up with the things out here. And the equally important component is the evacuation of the prostatic tissue and the clots from the bladder. Using LX evacuator is one of the ways. Otherwise, you can use Tomy glass Tomy syringe, which is mils. So you should know what sort of a glass syringe you have been using. Don't ignore those instruments, because in the exam, some basic questions will be asked from you, and you will be found wanting. And they will ask you what sort of you are using, and you say, I am using a Tomy glass syringe, and the examiner can ask you what capacity is that. So you should always see these small nuances. So this is how you evacuate the bladder of the prostatic chips. And you have to ensure that sometimes you have to use the guide wire. In this case, the surgeon is showing a guide wire for putting up a catheter. It is not very rare. Sometimes you need to do it, especially if you have a large medial lobe and you have resected the prostate. There is a shell there, so you need to do this thing. Or second maneuver is that somebody can put a finger in the rectum and push the catheter up to have the catheter in place. So distal limit, what defines it? The external sphincter muscle tends to slightly be tilted. So whenever you get an opportunity to do a cystoscopy as a resident, you always try to, you should not just put the scope inside and do a clot wash, remove the stent and go out. Do a cystoscopy very religiously, because if you do a good cystoscopy, that will help you when you're doing your TURPs to identify where the external sphincter is. And that will go a long way in your, career to doing a good, safe, and effective TURP. The verumontanum is the single most important anatomical landmark in the TURP. Remember that. You always, as somebody, one of my seniors told me, that it's like your mother-in-law, whether you like it or not, you got to respect it. So use of a finger, some old surgeons are more tuned to do that. I've never used a finger, but this is one of the ways to know two things. One, if you want to resect the median lobe, and second, what is the adequacy of what is the residual gland left there. So the finger can, tell you that. Now coming to the important question is, what are the techniques of doing a TURP? This is one of the techniques, is the Nesbitt technique. The Nesbitt technique is a very old one, and he originally described the Nesbitt in the procedure in 3 stages. So if somebody asks you what is a Nesbitt technique, the Nesbitt technique is the one in which you do your TURP starting at 12 o'clock position. Second thing, what you do is that you plan your TURP here in 3 categories. The one is the intravesical part, that is or the proximal part if there is no medial lobe, then the middle part of the prostate, and then the distal part of the prostate. So with that thing, what happens is that you don't feel lost. You're always oriented. You can take care of the things very nicely. So this is what Nesbitt technique of resection is. The main benefit of this is it is early control of the major prostatic blood vessels. And second is that this is intended to isolate, devascularize the bulk of the lateral lobe. So by the time you come to the middle portion of this thing, time in the patient. What is a Milner's resection technique? This initial reaction, the resection groove is made at 9 o'clock in the Milner's resection technique. Then from 9 o'clock or 3 o'clock, you make the initial incision, then go at 11 o'clock, then go at 3 o'clock, up and down, that is very important. So the final area of resection is anterior tissue between 11 and 1 o'clock positions. So again, you may call any technique, you may do any technique, but the important is just to follow a plan. You may start by the Nesbitts at 12 o'clock or Milner's at 9 o'clock, but you follow a definitive plan, how do you want to resect the things. The other techniques are Nathaniel and Alcock. They described his method as starting with one lateral lobe, completely resecting that up to the lower portion, and then starting from the other ways. And fourth one is the Holgate and others. They described a variation in the Nesbitt techniques by starting at 1 o'clock position. So now what I follow is this way. Majority of people follow this way. The advantage of this is that when you are doing a small prostate, you start at 1 o'clock position, and then you start at about 11 o'clock position, and you leave the strip of 12 o'clock position in the midline. That mucosa is important to prevent or avoid the bladder neck stenosis in the smaller prostates. What do you want to do? The other techniques include the laser enucleation of the prostate or the bipolar plasma transurethral resection. This is one of the videos I have requested Dr. Anshuman Kapoor to give it to me. So in this case, he has used a Karlstorff's vapor enucleation. You can see that the loop is different. In this case, he is starting at 5 o'clock position at the bladder neck. He makes a groove coming up right up to the veromontanum. So you can see the capsule very nicely. Basic is you may use any energy source for enucleation. You may use a cautery, you may use a bipolar cautery, you may use a thulmium laser, which is the the spice of the day. You may use the holmium laser. You may use the Moses technology for it. But the problem is that the basic principle remains the same. You can enucleate slowly, coagulate and enucleate, attain hemostasis nicely. And secondly, once you reach up to the bladder neck, then there are two options available with you. By that time, the whole of the prostate is devascularized. So if you have access to the morcellator, you can always throw back the lobes into the urinary bladder and use the morcellator, or you can resect, keep the hanging tissue to the bladder neck and go on doing the resection there for the avascular gland. So in this case, he has done one lobe. Now he's doing the anterior part of the prostate. The enucleation you can divide into three basic components, the right, left, and then the lobes, and then you go up to the anterior part of the gland, and slowly but steadily you have to just, speed has to be low, but ultimately it ends up doing a faster job than doing a TURP for the larger glands. So this is how it goes. It is just hanging through a small tissue and it is enucleated, and this will go into the bladder again. So now he's using a morcellator, Piranha, which the important component about the morcellator is that it should be in the middle of the bladder. Your bladder should always be partly or more than partly filled so as not to injure the bladder. You engage the prostate and then activate the tissue. There should be nothing should be blind and about that. You have to completely evacuate. And this is the post-void picture of a patient who is voiding that. So other new techniques include for the endourology purposes, for the examination purposes are the photoselective vaporization. It is a variety of the laser you want to use, or a Eurolift for a very high risk patients, or endoscopically putting the prostatic stents, which is also for very high risk patients from VIBA point of view, we can always state, but they are very sparingly and rarely being used. So just coming to the end, the important component to remember always is that the actual technique is probably not as important. Whichever technique, the Milner's, the Nesbit's, the others, whatever you want to use, it is not as important as planning it carefully and executing it precisely so that the operation is complete and the surgeon remains oriented throughout the procedure. So the take-home message is that once the resection has been started in a particular area, that portion of the resection should be finished completely before moving to another location. So from a candidate point of view, if somebody is asking you a question on a TURP, how you start, you can just say that I start at one lobe, finish it up, and then go to the opposite side. You don't move here and there and everywhere, then it starts to bleed, because performing a partial or incomplete resection in several lobes at once is discouraged because of the resultant increase in bleeding and fluid absorption. So if in the exam somebody asks you, there is a lot of bleeding, absolutely fine, you have done a TURP, you go back, patient is out, you have given a traction, and after 2 hours, somebody calls you from the OR, the post-op, and so thanks. That is what I had to talk about.
Hello. Hello.
Yes,
Dr. Avoli, thank you very much. It's a nice presentation. Actually, indeed, it's a wide and in-depth discussion in following TURP. And I request Dr. Sir, Dr. Sasanka, Dr. Srinivas, and Dr. Rahul to be there, and all three candidates to be there for short discussion of open prostatectomy. And Dr. Kalyan Sarkar, kindly. It may be discussed within 10 minutes so that we can have we can go to the next session of MCQ and point of the session. Kalyan Sarkar sir, please have a small discussion regarding open prostatectomy. All the three candidates kindly join.
Will you make yourself visible then?
Yes, I am visible.
No. The students have not made themselves visible.
Okay, and Dr. Prashant, Dr. Vishal and Dr. Shahid, you please be there with further discussion.
Yes, sir.
Okay. So Vishal, I'm sorry you are on the hot spot because none of the others, or Prashant, you can tell us. Have you seen the operation of open prostatectomy for large BPH?
Yes,
Yes,
sir.
sir.
So just go back to the last case that you remember, having done yourself or having assisted, and tell me how you did it.
First of all, after taking pre-anesthetic checkup, after clearance of pre-anesthetic.
No, please directly go to the operating part, not to other parts should not be discussed. Directly go to the operating part.
Steps of operation.
So I want you to think back.
Of operation.
Prashant,
yes,
I want you to think back the last case of open prostatectomy for benign prostatic hypertrophy, hyperplasia, that was performed in either by yourself or you assisted. And
Sir,
tell
I
us the steps
assisted.
of the operation.
What was the
Sir,
indication of doing it?
What, sir?
What was the indication of doing the open prostate? What are the indications
Sir,
of doing open
indication
prostate?
of open prostate or large prostate.
What is large?
Okay,
This is not the answer. What do you mean by large?
More than 80 gram, as European guidelines says. And sir, if patient have any orthopedic abnormality, like where lithotomy is not possible, then we can go for. If prostate associated with large tumor, then
large tumor.
Sorry, large stone or diverticular, which need to be a simultaneous treatment, or if patient refuse endological procedures.
Now, Prashant, this is an exam situation. So I have asked you a specific question to think back, which was the last case of open prostatectomy you did or you assisted, and take us to this operation. What operation was performed? I'm sure there was something performed in the last 6 months at least.
Yes, suprapubic fairs.
Sorry?
Suprapubic.
Freya's prostatectomy. Okay. So tell us the steps of Freya's prostatectomy.
So, first of all, sir, we position the patient in slight tenderloin position, and after that we do a lower midline incision and separate the transversalis fascia, and I forgot one step. First of all, we insert a 3 to 200 ml of NS in the bladder through 3-way catheter, which help us in identification of bladder during surgery. After opening the transversalis fascia, so we reflect the peritoneum from the bladder anteriorly, and then we made a vertical cystotomy incision and take a stake suture with the chromic catgut or Whitefield 30, and after that we inspect the whole bladder, and by self-retaining retractor, we retract the bladder and see the trigonal area. And by the device retractor, we just depress the trigonal area and make a circular incision just distal to the bladder neck. After that, we dissected.
Before making a circular incision, will you do something else? Because these are the large prostate, there is a gross obstruction, lot of trabeculation, circulation, and diverticular formation will be there within the bladder.
So if diverticular present, we first
I'm
address
talking about the obstructive changes will be there. So we would like to do before making the incision all around the bladder neck, taking the median lobe. Would you like to do anything or inspect for anything else nearby?
Sir, identify ureteric orifice before.
Important, identifying the ureteric orifices. So that you never forget. That is one of the steps, that identification. Even sometimes we cannulate the during the open prostatectomy because it is very difficult to identify even. Sometimes it may not be visible with your naked eye. Then you ask the anesthetist to give furosemide injection. Then you look for the efflux of urine and you catheterize with the 6 French feeding tube. So that while making an incision, you do not go beyond that and injure the ureteric orifice.
Yes, sir. Yes,
Very
sir.
important step of identifying the ureteric orifices.
So after giving incisions, we just starting dissect from 6 o'clock position to the both first right lateral, then left lateral side, and we encircle our finger around the prostatic adenocarcinoma and prostatic capsule, and remove the prostatic adenoma. After that, we close bladder in 2 layer and put a suprapubic catheter and close bladder in 2 layer and a separate drain for any hematoma or urine leaks.
What are the various ways you obtain hemostasis in a?
So there's 3 type of. So there is 3 type of sutures we use. So first is Halsted suture, which is first sting suture at the 5 and 7 o'clock position, and second one Malamant stitch, which is the nylon suture around the prostatovesical junction, and traction cap and pull out through skin and traction for 2 to 3 days, and one is O'Connell suture, which is transverse posterior prostatic stitch suture.
So tell me about this operation. Say you have uncontrollable bleeding at the end of you have severe bleeding at the end of open prostatectomy, and you have given the 5 o'clock and the 7 o'clock sutures and they have not worked.
So packing of fossa, prostatic fossa. Packing of prostatic fossa, sir.
So why did you choose to do Freyr's operation?
What's it?
In the contemporary day and age, is Freyr's transvesical prostatectomy a very standard procedure? What are the specific situations when you have to do Freyr's prostatectomy? Is there
it's a very large median lobe and it's associated with any bladder pathology which simultaneously deal like large bladder stones.
Exactly. So, Vishal, tell me, tell me 1 or 2 other things about this classical Freyr's prostatectomy, which examiners may ask you. There are 1 or 2 little things like the retrigonization stitches. Do you know, have you heard of that? Retrigonization stitches.
Oh, sure. No, sir.
Well, you can advance the trigone into the prostatic fossa by suture. These are called the retrigonization stitches. So anyway, so okay, you've told us about transvesical prostatectomy. The other thing is that you mentioned Freyr's operation. Who was Freyr? Sir Peter Freyr was a army surgeon. in 1995, and he devised the first Frere's lithotrite to crush bladder stones when he worked in Benares. He was, I think he was a member of the British Army, or then British Army. So he devised the Frere's lithotrite, and then he practiced and developed Frere's operation for the process. So that's his contribution to the world. So, Vishal or Shahid, can you tell me about other ways of open prostatectomy that you know for a large BPH?
Other one is million open prostatectomy, retropubic millions
Vishal, will it?
prostatectomy. Hello.
Who can tell me about Millen's prostatectomy step by step?
Yes, sir. After the painting, draping, and lower midline incision given from umbilicus to pubic symphysis, subcutaneous flare and anterior sheath open. Then space of ridges space along with before starting the procedure. Initially, the bladder is empty with catheter put and 30 cc balloon inflated at the level of the bladder neck. And then after the space of ridges are identified, then self-retaining retractor are put with non-traumatic blade are applied, and then after the pre-prostatic tissue are dissected and identify superficial and deep dorsal venous plexus. And then after control before opening the prostate, DVC should be ligated and in figure of 8. And then after the endopelvic fascia open and puboprostatic ligament identify, and along with the 30 mm balloon filled to identify the vesicoprostatic junction. And after the bladder push forward, downward and forward, and the transverse capsulotomy done. Transverse capsulotomy done between the prostatic capsule and adenoma tissue, and the space developed between the adenoma and capsule done in first with the left lobe, and depend upon one by one lobe. And after dissection done, and then after dissection do up to the apex and apex tissue under vision cut to prevent incontinence. If the median lobe also present, and then incision should be given mucosa over the bladder neck, and median lobe should be removed. Benefit of the after in this Millions procedure, and to direct check the any bleeder point, and if any bleeder point found, then should be controlled. And after adequate hemostasis, and the capsulotomy is closed by the Vicryl in watertight fashion, and catheter put, and then after the sheath and abdomen is closed in layer.
There is one important step of the Millen's prostatectomy which you have missed. This is done at the very beginning of this procedure. What is that? Shahid, can you tell me, or any of you? What is the fundamental difference between the transvesical Frere's operation and the Millen's operation? There is a mandatory investigation before you do Millen's operation.
Yes, sir. Check. Sir, check any intravesical pathology, sir.
By how do you check for that?
Cystoscopy.
Cystoscopy. So cystoscopy is an essential investigation before Millen's prostatectomy. So who was Millen? So Sir Terence Millen was an Irish surgeon. He devised the operation of Millen's prostatectomy in 1948 or 46. It was published in the British Journal of Surgery. So what are the main advantages of Millen's prostatectomy over Fryer's prostatectomy?
Look, these are the questions asked even in the MS General Surgery. Dr. Sarkar is asking you questions. Those are even asked in the MS General Surgery.
Yes, sir. If sir, more control, sir, better control any bleeding site in the millions, and less post-operative bladder spasm in millions procedure.
One is under vision. One is under vision.
Under vision, yes, sir. Under vision control of any bladder point in the prostate.
No,
Second is the
the prostatic adenoma is taken out under vision, and in Freer, the prostatic adenoma is a blind procedure.
Blind procedure, yes, sir. Second one is the chance of incontinence low in millions because of the apex also cut under the vision, sir. Third one, the post-operative bladder spasm and bladder-related complication are low in millions, sir, over the Freers.
Do you need to open the bladder in Millen's prostatectomy?
No, sir.
So that has to be highlighted.
I was a bit disappointed in the way you presented, this is an operative chat, is part of all surgical exams. And you must be much more prepared in answering these steps of basic steps of operation. And this includes you must mention about taking that after consenting of the patient and pre-anesthetic preparation, you must stay the basic anesthesia, what is required, that these can be done under regional anesthesia, and after these are important things. When you are asked in an exam these days in the medical legal steps, which Professor Badua was stressing, these days you've got to mention that you take consent, you do go through the surgical checklist. There is something called a surgical checklist. You must make sure that you're operating on the correct patient, on the correct side. All the investigations of the patient are reviewed, and then proper antiseptic dressing, draping, etc., etc., etc. So these are things which impress the examiner. So you'll be asked very simple things, actually, and you can't afford to miss these. And when you are coming out from the exit exam for a specialist, for a postdoctoral qualification. So
Dr. Rahul or Dr. Srinivas can add anything regarding open prostatectomy?
See, open prostatectomy is a very good procedure, but the only thing is that you need to learn that procedure in a nice way from a senior person. One, you should have a good suction and a good vision. These two things are mandatory to do, open prostatectomy. Third thing is you have to arrange blood. You cannot put a patient for open prostatectomy. He may need no blood and he may need a lot of blood. So at least what my protocol is that I arrange at least 2 to 3 units of blood before I take up the patient for open prostatectomy. Fourth, don't try to take hemostasis when you're doing an open prostatectomy. When you're doing an open prostatectomy, it is bound to bleed. If you try to take a very good hemostasis, see the corner stitches, angle stitches you have to take. You have to take the bladder neck reconstruction. There is no doubt about it. Spend some time there and then put a big caliber Foley's catheter. What I use is 22 French Foley catheter minimum for an open prostatectomy. For TURP and the other things, I use only 20 French, but for open 22 to 24 French Foleys, and then you give a good traction to that and have patience. More you try to spend time inside trying to achieve hemostasis, taking stitch here and there and other places, it will not help. The patient goes into hypertension and things are bad. Third, if the patient is bleeding and you're not able to control the bleeding, you put a pack, come out, wait and take out the pack slowly, the patient will be fine. So that is the few points I wanted to highlight for open.
Okay, Dr. Srinivas, anything you want to add?
I should not be commenting on open prostate,
No,
which
yes,
I haven't
absolutely.
done in last 15 years.
Okay,
After my MCS training.
Yes, absolutely. Actually, Dr. Kalyan sir is probably the right person to guide everybody. So it's a nice session, and I think one point we have missed transperineal approach, but probably nobody is doing that. So millions and Frias are the common methods to be done. And regarding difficult catheterization post TRP, when there is the neck is a little bit angulated in a difficult situation, catheter guide, metal catheter guide can help in difficult situation. And just to add the session of Dr. Rahul. So, Dr. Rahul, are you ready with the self-assessment question and MCQ?
Sorry?
Self-assessment questions and MCQ.
I don't have them. Okay. I was asked to do only this thing.
Okay, no problem, no problem. So, Dr. Kalyan sir can add any point? Kalyan sir and Dr. Satanko?
But for the academic interest, continuing with the open prostatectomy, I'd like to student whether they know there are any other approach of open prostatectomy.
Yes,
apart from
candidates, please answer. Candidates, please answer the questions.
So, Young's perineal operation?
Yeah,
Young's perineal.
Perineal prostatectomy, although not done nowadays, but this was one of the approach in those days. Hello. Oh, wow.
Okay, regarding various type of instruments and all, genuinely, I must tell one point. In various exams throughout country, usually the history and other thing is being asked regarding the instruments what Dr. Rahul has shown. Probably even I have not encountered this type of instrument. Probably during examination, what the current instruments are being used, those questions should have been asked. But I don't know whether that's a valid question or valid choice. I don't know. But as of now, what the students are exposed to during 3 years, those are the instruments should be asked by the examiner. Anyway, but as per the knowledge, all the students must know each and every points of the techniques, every points regarding theory, and every points regarding the technique of surgery as well as the instruments proper. So
just actually the other instruments what I've shown is just for the extra marks. By the time the candidate reaches there, he's already passed the exam. That is for that is for extra points he wants to. If somebody
actually, my personal view is it's a common question. What you have shown and your presentation is excellent. Actually, each and every points are regularly asked. But I personally believe the history instrument should not be asked to the candidates during examination because those are really not going to help him out in near future or may not be. These are the instruments to be used. So probably he should know each and every point about the instrument he is using or going to use. That's the point I just wanted to help. But overall, it's a very nice presentation and nice discussion. Special thanks to Kalyan sir and all the presenters, Dr. Srinivas, Dr. Rahul, and Dr. Shashank Barua. So over to you, Dr. Ranjan sir.
Thank you very much, Samir. It's a big attempt. I appreciate today the effort of the teachers. Even many of the teachers were not given adequate time to prepare themselves for this class, but the quality they have shown is really remarkable. And I must thank all of them are very busy surgeons and the busy teachers. They have many other commitments. In spite of that, the amount of commitment they have shown for this society's activity, and I am personally highly obliged. But only thing I must say, which I am observing today, students were not properly prepared for this serious class. They did not take it seriously, in spite of the fact that the teachers have given a lot of effort to give them input so that they can do well in the exam. Many of the very humble to answer is really to put a question whether the basic teaching is going on in the right way throughout the zone. Anyway, I don't want to criticize anybody. I only encourage students that get prepared for these simple questions in your examination. And the effort, always remember that the effort that your teachers have given to give you the I must once again individually thank Dr. Rahul, from Jammu. He has given so much of effort and such a brief and precise presentation on the endosurgical management of this BPH. Thank you, Rahul. In near future, we will meet more frequently in different forums.
Yes,
and I appreciate
Thank you for having me.
appreciate your
Thank you
effort.
for having me. It's
Thank
always
you
a
very
pleasure.
much.
Thank you so much.
And thank you, Dr. Sharkar. Thank you, Srinivas. Thank you, Shashank, Professor and Head of Guwahati Medical College, for your serious effort to educate the students. And next tomorrow we are going to finish these 2.5 months long session with the andrology, with the hope that we will also enlighten ourselves with this less practiced aspect on the urology. I welcome you all for tomorrow's program. Thank you very much and good night to everybody. And once again, thanks to everybody. Good night.
Thank you, sir. Good night. Good night, everyone.
Good night. Good night. Good night. Thank you, Shashank. Bye.